I'd like to welcome you, Dr. Mahtani.
Thank you, Janine. Thank you all for having me.
We're so pleased to have you with us tonight. So while we're polling for some questions, we know that we have some folks with us tonight who are very newly diagnosed. Can you just briefly explain why is it important for people to know the type or the subtype of breast cancer in order to access these targeted therapies we're discussing this evening?
That's a great question. I think that we're increasingly becoming aware that breast cancer is not just one disease, and it's very much guided by the subtype of breast cancer that you have. So initially, when you're diagnosed, it's really important to understand the subtype you have, and there are various subtypes, primarily hormone receptor positive tumors, where we can give anti-estrogen therapy, HER2 positive tumors that can also be estrogen receptor positive or negative. And those subtypes of breast cancer, or that subtype rather, can really effectively be targeted by a treatment that is anti-HER2 therapy. And we'll talk more about that. And then triple negative breast cancers where they don't express the estrogen receptor, progesterone receptor, or HER2, where we really are struggling to find more therapies for those patients, with chemotherapy being the primary treatment in that subtype. So understanding what subtype you have really dictates the type of treatment that you're going to be offered. And in oncology, we have a saying, tissue is the issue, meaning that we are really guiding our treatment decisions based on these factors.
Thanks very much for explaining that, Dr. Mahtani. And just really briefly, what are the tests that help you understand the subtype? I know there's a lot of them, but for sort of ER, PR, and HER2, what are the tests that people should make sure that they're getting so that they know what the subtype is?
Yeah, so I think nowadays it's pretty standard that these tests are done on the tissue automatically. So a pathologist is going to recognize, once this is a breast cancer, that the medical oncologist, the surgeon, they're really going to need this information to get a sense of not only what treatment may be offered, but also give us some information that might be prognostic, meaning help the patient understand how they're expected to do long term. So there is information in the pathology report that is sort of automatic at this point, and that includes the size of the tumor, the grade of the tumor, if it went to lymph nodes, and then again, ER, PR, and HER2 are tests that are automatically done. It's not something you really need to ask for when you're first diagnosed with breast cancer.
Thank you. Thanks for answering that. And are there ever situations where it's uncertain whether you're positive or negative, particularly in sort of the HER2 situation where you might get it?
That's a great question. You know, we recognized HER2 as a gene that's very important in about 20% of breast cancers. 1 in 5 women will have too many copies of this gene in their tumor. And this was recognized to be a particularly aggressive subtype of breast cancer now close to 30 years ago. And initially, when we first diagnosed this type of breast cancer, there wasn't really too much we could do about it, only to know that this patient wouldn't likely do well. And flash forward now, many years later, HER2-positive breast cancer is actually one of the better types of breast cancer to have, because there are so many targeted treatments against this subtype. But the benefits of those therapies are clearly linked to appropriately identifying who has a HER2-positive tumor and who doesn't. So we now have pretty clear guidelines. They have been updated on various occasions. We're now at the 3rd iteration of what we call the ASCO-CAP guidelines. These are guidelines that the pathologists use to clearly identify a tumor as either HER2 positive or HER2 negative. And it kind of got rid of this gray zone, so to speak, and really clarified situations where it was confusing for the pathologist and also for the medical oncologist like myself to make a decision of whether to offer treatment or not. So we've come a far way in terms of our refinement of HER2 testing.
Thanks for addressing that. And actually, I think with that, we've already got a whole bunch of really excellent questions. So I'm just going to jump into some of those. And I think this one sort of is a good lead to what you just talked about. So one of our attendees is saying that she was diagnosed triple positive, so hormone receptor positive and HER2 positive. When you have a triple positive disease, how do you know what is really driving the tumor growth the most? And how does that matter in the treatment?
That's a wonderful question. And I think it is very in tune with where we are doing a lot of research, because we're recognizing that an ER negative HER2 positive tumor may behave differently in terms of when that tumor may recur versus an ER positive HER2 positive tumor where you can see recurrences much later on. And understanding what the driver of that disease has been a challenge, because to date we've really treated a lot of these patients very similarly, only with the addition of hormonal therapy in the ER positive tumors. But we also do have an additional treatment in the early stage setting that could particularly be of benefit in triple positive tumors. And that's a drug called Neratinib. This is a small molecule that's an oral pill that in patients with a particularly high risk of recurrence, we've seen that adding this drug Neratinib for a year beyond standard HER2 therapy further decreases the risk of recurrence. And a lot of this is thought to be related to the crosstalk that happens between the ER pathway and the HER2 pathway, where we see a real benefit in this with this particular agent. But that's a great question, because I think that we are still struggling to understand what the drivers of the disease are in that subtype, which may be clearly a totally different entity.
Thank you. Yeah, that's it's a really common question. And I think that that medication was just approved in the last couple of years. So it's clearly an area that researchers are looking at and wanting to learn more. So as a follow-up to that question, another attendee has only HER2 positive breast cancer and is asking, in that situation, once you are done with active treatment, what are some things that can be done to lower the risk of recurrence?
Yeah,
no evidence of disease.
Yeah, this is a question that we get very often in clinic, and especially with patients that are HER2 positive, because they're often really comforted by the fact that they're coming in every 3 weeks to complete 1 year of anti-HER2 therapy. And I think from what I've heard from my patients, there's a certain level of comfort that comes with coming into the office every 3 weeks. You start to develop relationships with the nurses and everybody there that's taking care of you. And you know that if something is going on, you're going to have the opportunity to speak with someone. But then at that time where the treatment is finished, the year is over, we often think as oncologists that our patients are going to feel this immense sense of relief that I'm done and I am kind of finished with this place for a few months. But more often than not, we get a lot of anxiety at that time point, because patients have this feeling that, well, I'm not being watched anymore. And what can I do? Well, the important thing to realize at that point is that as we're looking for signs of recurrence, we're still seeing you in follow-up. So you're going to be monitored with physical exam, blood work, certainly mammograms and MRI if indicated, breast imaging. There are things that you can do from a lifestyle standpoint in terms of weight loss, limiting alcohol intake. There are a lot of lifestyle interventions that can really reduce the risk beyond just the standard treatments that we give. And those things are clearly in the hands of our patients.
Thanks, Dr. Mahtani. So staying with, I'm going to ask a couple more HER2 positive questions, and then I see we have lots of questions from people on hormonal therapies, and so we'll be asking those as well. We have someone asking an interesting question about a lot of the HER2 therapies are given neoadjuvantly before surgery. Can you talk a little bit about why neoadjuvant therapy might not work at eliminating the cancer? And what are the reasons you wouldn't have surgery first before starting the HER2 targeting therapy?
Yeah, we're getting great questions tonight. These are really wonderful. So it's always a bit of a challenge to try to explain the concept of neoadjuvant therapy in that we are able to use the information to help us prognosticate or allow us to know how you're likely to do going forward. It's challenging in that I think a lot of women, when they especially can feel a tumor in their breast, there's this sense of, I want it out, right? And the conversation regarding neoadjuvant therapy in my office usually goes something like this. When the tumor is in the breast and we give you chemotherapy and HER2-directed therapy, we're hopefully going to feel it shrinking while you're on treatment. And that is somewhat reassuring, as opposed to if you go for surgery up front and then we give you chemotherapy and you're wondering, is it quote unquote working? There's really no way for us to measure that that response. The other piece of information that can really be helpful is at the time of surgery, if there is no tumor left in the specimen, in the breast and in the lymph nodes, we call that a complete pathologic response. And there are a large percentage of patients, somewhere around 60% or so, even up to about 70%, is particularly with ER negative HER2 positive tumors, that can get to a complete pathologic response with treatment. And we know those women are likely to do very well going forward in terms of their risk of recurrence. Conversely, the women that do not have a complete pathologic response, we don't know always what is driving that resistance. That's the subject of investigation. But the good news is we have a very effective therapy that was approved in 2019. It is a treatment that is currently approved in the metastatic setting and was then moved up to the early stage setting. It's called TDM1. And that therapy for these higher risk patients that do have residual disease at the time of surgery, and we're concerned about what that means for their risk of relapse later, we know their risk is higher. That treatment is very effective in reducing that risk of recurrence.
Thanks for addressing that, Dr. Mahtani. And another person on our call today is actually asking what we know about the risks for recurrence for people with ER positive breast cancer versus HER2 positive. Do we have understanding about whether the risks of recurrence are different or the percentages are different based on the type of breast cancer?
Well, I think there is information that we have in terms of the aggressiveness of HER2 positive tumors. We tend to treat them when they're even smaller as opposed to an ER positive HER2 negative tumor, because we know the underlying biology of those HER2 positive tumors can make it such that even a smaller tumor, there is a considerable risk such that it would warrant receiving treatment. A lot of our information about risk of recurrence is really based on the initial presentation of the stage of disease, right? So a large tumor with lymph node positivity, the risk of recurrence at baseline, whether it's an ER positive or HER2 positive tumor, you have to look at the stage at presentation. That certainly informs the risk, but the biology certainly informs it as well. And that's where I mentioned that a HER2 positive tumor that's even smaller, we may consider treating as opposed to that same size tumor that's ER positive and HER2 negative. And then in terms of how you're going to assess for risk of recurrence going forward, we know that ER positive breast cancers can unfortunately recur later in after treatment, and out of all the women that have a recurrence, 50% of those actually happen after 5 years, which is something that is kind of hard to accept, because I think a lot of patients hang on to this 5-year time point. It certainly does mean a lot if you get to that 5-year mark and you haven't had a recurrence. But there is the possibility of a recurrence even after 5 years, particularly for ER-positive tumors.
And Dr. Mahtani, when you're talking with someone in your office who's concerned about these risks for recurrence, what are the ways that you talk with a person about how to manage their concerns around recurrence?
Yeah. So, I think this is something that a lot of patients deal with from the emotional standpoint of it. It becomes very difficult when you're diagnosed. There's never a good time to hear those words that you have breast cancer, right? We're all busy in our lives, and it disrupts our life, and it disrupts our sense of well-being and our sense of control. And I think as women, we are very used to being in control of our situation, and we try to tackle that head on. I think that in terms of how I counsel my patients to handle the anxiety part of monitoring for recurrence, I think that's where you have to draw in your support network of friends and family and wonderful organizations like this one to get accurate information about what you can do, from lifestyle modification to being adherent to the medications that you're being prescribed by your physicians, and really use it as an opportunity to get the help of your team.
Thanks, Dr. Mahtani. And I can see a number of people are expressing these concerns, and just want all of you to know that we offer a helpline. And for those who are really concerned, after talking with your doctor, if you want to talk to someone who has had these concerns and these worries about the ways they manage their fears of recurrence, we really encourage you to reach out to us, and we'd be happy to match you. So I have a number of questions actually about hormonal therapies. So I'm going to transition to that. So for the first question, we have someone who is asking, should you take an aromatase inhibitor for longer than 5 years? And I wonder, Dr. Mahtani, if you could just sort of briefly explain what are the current standards for taking hormonal therapy if you're premenopausal versus postmenopausal.
Mm-hmm. So for a premenopausal woman, who has an estrogen-driven tumor, or hormone receptor-positive tumor, it is standard to take hormonal therapy for 5 years, with the consideration to extend beyond 5 years in certain situations. And I can talk about that in a moment. Options for premenopausal women include tamoxifen alone, tamoxifen plus shutting your ovaries down, and that can be accomplished by either surgery or a shot that is given on a monthly basis. Or another drug called an aromatase inhibitor, which is really a class of therapy. There are multiple aromatase inhibitors, plus ovarian suppression. Again, we're talking about premenopausal women. If a premenopausal woman is given an aromatase inhibitor, her ovarian function needs to be suppressed. As a postmenopausal woman, she can take an aromatase inhibitor alone or tamoxifen alone.
Great. And what do we know about taking aromatase inhibitors for longer than 5 years? I know this is something many people ask us, should I take it longer than 5 years?
Yeah. So the benefit of taking an additional 5 years of therapy has been looked at in various trials. And a lot of those studies have either looked at 5 years of tamoxifen followed by 5 years of an aromatase inhibitor. The first 5 years, some combination of tamoxifen and an aromatase inhibitor, followed by additional 5 years of an AI, or even 10 years of tamoxifen. And we know across the board that there is about a 3 to 5% additional reduction in risk of recurrence by extending to the additional 5 years. But the challenge really is in identifying who's getting the benefit, and some women are just getting the toxic side effects of these drugs. So we've classically used clinical and pathologic factors like the size of the tumor, lymph node involvement to make these decisions about who is likely to have a longer duration of endocrine therapy because their risk is such that it warrants additional treatment. Oftentimes, clinical and pathologic features are very helpful, but they're not always 100% accurate. There are now diagnostic tests that can help us identify what the risk is of a late distant recurrence. One that I've used quite a bit in my practice is called the Breast Cancer Index. It is a test that gives you your risk of late distant recurrence, meaning after 5 years. And it also helps identify whether taking endocrine therapy for an additional 5 years is of potential benefit, because all of these tumors may not benefit from continuing endocrine suppression. And we always have to balance our side effects and risks of taking this additional therapy with the benefits. And some women are just getting the risks or the side effects and not much of the benefit.
Yes, and we have a number of questions about the side effects of some of these medications. So one person is asking about joint pain with aromatase inhibitors and what advice you provide. Or is there anything you can do if you get joint pain from aromatase inhibitors?
So it's pretty common to get joint pain on aromatase inhibitors. Usually the symptoms start after about a month or so after being on the treatment, and they tend to peak around month 3, 4, 5. And then by the time you get to around 6 months, for a lot of women, the side effects kind of flatten and steady off, and some women are able to adjust to it and stay on. In my practice, I can tell you that I have a lot of visits talking about management of joint pain and hot flashes, sexual side effects, other side effects related to these drugs. And it's become a challenge to have some of these patients stay on the treatment. I would say the number one thing that has been shown to really help with the joint pain is weight loss and staying active. So exercise and staying active and keeping active, moving at least 30 minutes, 4 to 5 times a week has been the only thing that's reliably been shown to reduce joint discomfort. Taking anti-inflammatories intermittently, because you don't want to live on those medications, has been helpful. There's some data with acupuncture that was reported a few years ago at a major meeting that showed that acupuncture can be very helpful. So, these are some of the strategies we use, but again, this is a major side effect of the drug. And for, unfortunately, some women, it results in them coming off the medication or having to switch to another one because there are differences in tolerance to these medicines.
So that was going to be my follow-up question is, whether it makes a difference to switch and whether there's any way to know whether switching would help with joint pain or with other side effects.
Yeah. So out of the aromatase inhibitors, there are 3. There's anastrozole, letrozole, and a third called exemestane. And the way that I describe these medicines to my patients is you have to imagine they're kind of a family. So exemestane or anastrozole and letrozole are 2 siblings, and exemestane is like the cousin. So in the same family, but chemically slightly different. And what I typically do is I start with one of the non-steroidal aromatase inhibitors, either letrozole or anastrozole. And if a patient has serious tolerance issues, I would switch to exemestane. Sometimes we have to switch to tamoxifen. And we know that in postmenopausal women, aromatase inhibitors are slightly superior to tamoxifen in reducing the risk of recurrence. So typically we do try to start with an aromatase inhibitor, but again, this is where we get back to what is your baseline risk of recurrence. If you had a very small lymph node negative tumor, the benefit of an aromatase inhibitor over tamoxifen may really be outweighed by the side effects that you're experiencing, as opposed to if you had a 5-centimeter tumor with 15 positive nodes, your risk of recurrence is considerable, and you really may be benefiting from that differential benefit of the AI over tamoxifen.
So it's really a conversation with your
Absolutely.
healthcare professional about weighing what works for you and the risks you are comfortable with.
Yeah. And I think the other thing that I would just stress is that I find that sometimes patients are a little bit hesitant to tell their physician that they're not taking the medication. And there is this knowledge that we have that there are patients that are just either filling the medication and not taking it, or taking it every other day, or taking it for a month and staying off for 3 months. We don't want to make anyone miserable for 5 or 10 years. We're looking to have you have a certain quality of life. And I would just encourage you to be honest with your physician. And if it's not working for you, we would rather know. And even if it means that you ended up coming off the medicine, at least we know what your risk is, so that we know how to monitor you and how to perceive your risk going forward.
So you really want that information. You want to hear from your patient.
Absolutely. And I mean, I encourage my patients to be honest and let me know there are strategies that we can investigate in terms of supportive treatments. There are a lot of newer therapies out there. For example, we've had a lot of women suffering with hot flashes for many years, and there are supplements that can be taken that are non-hormonal. There was a study looking at a drug called oxybutynin, which is used for urinary retention, but can be very effective in managing hot flashes. There's acupuncture. There are a lot of different things that we can do, but we don't know to offer them to you if you're suffering silently.
Thanks for addressing that. And just one more follow-up about a side effect. A couple of people are asking about hair thinning with aromatase inhibitors and whether there's anything that can be done for that.
Yeah, I think this is something, again, that we are struggling to help patients with. When we give anti-estrogen treatment, thinning of the hair and hair loss even, but mainly hair thinning is a very common side effect. Just switching from one to the other may help with that side effect, but otherwise I'm not aware of anything that's been very successful in managing that side effect.
Thank you. So we have a couple of questions, really excellent questions about risk for recurrence. So one attendee is asking, if the recurrence risk for hormone-positive breast cancer lasts 15 to 20 years, why only take hormone suppressors for 5 to 10 years? Could you address that?
Wonderful question. So first, I would just say that the farther away you get from your diagnosis, your prognosis improves. It's not that we see a huge number of patients relapsing 15 or 20 years later. Certainly, the really aggressive cancers can actually come back in those first 5 years, which is what I meant earlier when I said that getting to that 5-year time point is important, because there are certain women that will recur right there at that 5-year mark. Around year 7 or 8, there's another peak relapse time period. And then it does go down, but it kind of still persists as we get even out to 15 to 20 years. And there is the thought that for some women, the risk is many years out. And for those women, we may consider extending to 10 years. There is what we call a carryover benefit. So when you take the anti-estrogen therapy for 5 years versus 10 years, you actually start to see recurrence reductions even 15 years and beyond because of that carryover side effect. And typically we are giving hormonal therapy for 10 years because we're balancing, again, the risks, especially with a drug like tamoxifen, where there's a risk of uterine cancer, and that's certainly time dependent. We have to balance that risk. We certainly have to balance the risk of bone loss. There's increasing evidence that the aromatase inhibitors can cause issues with some cardiovascular issues, cholesterol, and anti-estrogen therapy in general, cognitive issues can present. So we certainly need to balance those risks and understand that not all women have this really, really high risk at 15 to 20 years where they need to take it for such long durations.
And Dr. Mahtani, for people who are concerned about some of these longer term side effects, how are people monitored for these longer term side effects, either with the hormonal therapies or with the HER2 targeting therapies? Is that something that you do as the medical oncologist in follow-up, or is that something that the primary care physician does?
I think that varies depending on your oncologist and how long they follow you. A lot of physicians, after a certain time period, patients are seen in survivorship clinics or maybe referred back to their primary. I think that a lot of patients feel very comforted to at least see their oncologist even years later. I mean, I have patients in my practice who 10 years ago had a cancer, and I tell them, you know, it was a very small node negative tumor. We're 10, 12 years out. You're likely cured, and you can go back to see your primary care physician, but they still want to be seen, and that's completely fine. There's a bond that develops there. But in terms of the way that patients are monitored, it's physical exam, mammography, all of those things going forward.
Okay, thank you for answering that. We have a couple of questions from some younger women who are wanting some information about fertility and the safety of trying to have children after a diagnosis of breast cancer. So one question is whether it's how you would time fertility treatments or egg preservation with your treatment. Can you do it after your treatment but before starting hormonal therapy, or is there a more optimal time to do that?
So for women, and we're seeing younger women being diagnosed with breast cancer, this is always something that prompts a very early referral to our endocrinology and fertility colleagues, because our reproductive endocrinology colleagues, because we really want to make sure that these patients are seen early. And if there's egg harvesting that is to be done, we try to time that before we start chemotherapy. A lot of the chemotherapy drugs that we give can affect ovarian function. There is an option to give a medication that is suppressing ovarian function, a shot, and there's some data to suggest that if you give that during chemotherapy, that there may be some benefits in preserving ovarian function. We certainly don't want to take away a woman's ability later on after a breast cancer diagnosis to be able to conceive, or at least have options like surrogacy and other options. So we try to get our fertility colleagues engaged early on. And there are no data that suggests, and in fact, conversely, that are assuring that getting pregnant after a breast cancer diagnosis is not unsafe in terms of sparking a recurrence. But what I would say is that a lot of the medications that we give, especially for ER-positive tumors, tamoxifen is not a drug that you should get pregnant on. It can cause birth defects. It's teratogenic. So the timing of this does become something that we should discuss early on, because there may be a situation where after the chemotherapy and the 5 years of anti-estrogen therapy, there may be an issue where pregnancy might not be as possible because of the age of the woman, and that's where egg harvesting and other options should be discussed early on.
Great, thank you. Another question, a different kind of question that we actually received over social media, so we got a number of great questions there, is about how you would counsel someone about whether to choose the surgical removal of ovaries over ovarian suppression or taking medication for someone who might be hesitant about doing one or the other.
Mm-hmm. So just to take a step back, again, we're talking about a premenopausal woman who needs to do something with regards to ovarian function because her physician has determined that her risk of recurrence is high enough that she would benefit from not only taking either tamoxifen or an aromatase inhibitor, but also shutting down her ovaries. So we know based on 8-year follow-up of large trials that included thousands of women, that approach is beneficial as compared to tamoxifen alone. But really, that approach is most beneficial in women that have a higher baseline risk of recurrence. So larger tumors, lymph node positive disease, women that were younger, required chemotherapy. In terms of which strategy to go with, now we've made the decision that the risk is such that that approach is being recommended. I always counsel my patients to start with the shots, because at least you get the opportunity to feel, to get used to what it feels like to have the ovaries shut down, as opposed to rushing into surgery. And that's an irreversible procedure, right? Your ovaries are out, you're put into menopause. And that can be quite shocking to the system. Taking a shot monthly and getting used to it, and maybe considering how you're doing on it, if you end up having to stop the shots because you're just not able to tolerate it, at least there's that option there, as opposed to going into surgery up front.
Thanks for answering that. And sort of with, this is a somewhat similar question, but there's a number of people on the call who they're not sure whether they're postmenopausal and are trying to decide about whether to take tamoxifen or an aromatase inhibitor. Is there any definitive way besides tracking your monthly cycle to know whether you're in menopause so you can make that switch?
Yeah, that becomes a challenge, not only for patients, but for physicians who have to make that determination as we're giving anti-estrogen therapy. And there's a woman, for example, who's not tolerating tamoxifen or has some contraindication to tamoxifen and may need to take an aromatase inhibitor. We have to make a decision, is this woman menopausal or not? And many times there is sort of a temporary menopause that's the result of receiving chemotherapy. The closer you are to natural menopause, which occurs around 51 to 52, but isn't an absolute thing, because we have women who are 45 who go into natural menopause, and other women who are still menstruating and they're 54 and 55. The closer you are to natural menopause for you at the time that you receive chemotherapy, the more likely you are to be in permanent menopause, but it's difficult to know that for sure. So the definition of menopause is no menstrual period for 1 year and blood work that's in the postmenopausal range. So the no menstrual period part is easy if you have your uterus in place and you're not having monthly cycles. The menopausal blood work can be challenging to interpret, because drugs like tamoxifen can make some of that lab work unreliable. So what I would typically do in that situation is check monthly estradiol levels in a woman that I am giving an aromatase inhibitor alone to, and I'm worried that she may not indeed be postmenopausal, because if you give a premenopausal woman an aromatase inhibitor alone and you don't shut her ovarian function off, you are not fully suppressing her estrogen. And that obviously is not ideal, because you're not adequately treating her breast cancer. So if that estradiol level starts going up over 15, and I've had some women even actually have a period, then you know that that woman's ovaries are still functional and she needs to have them shut down with monthly ovarian suppression shots or surgically.
Thank you for answering that question. We have another question from an attendee who is asking, is hormonal therapy always needed for early breast cancer treatment after surgery and radiation?
Well, I would say it's the standard treatment that we give, but there are certainly situations where we may deviate from that. For example, there are women with stage 0 breast cancer, DCIS, we call it. And some of these women may have a sufficiently low risk of recurrence that we may consider. There are studies looking at women who have DCIS and not necessarily offering them anti-estrogen therapy. But for an invasive breast cancer that is estrogen receptor positive, the standard recommendation is to take the medication for at least 5 years.
Okay, thank you for answering that. There's also a couple of questions about tumor biomarker testing, which we haven't discussed yet. And can you talk a little bit just about who would be eligible for that kind of testing and what you would be looking for to make a medical recommendation based on it?
When the individual said tumor biomarker testing, I assumed that they're referring to something that we call genomic testing, which is different than genetic testing, right? I think this is a nuance that gets lost sometimes, and it's worth just pausing and making sure everybody understands. When we talk about genetic testing, we're talking about looking for a gene that may be mutated, that you inherited from your mom or your dad, that actually caused your breast cancer to develop. It informs your risk of developing breast cancer, as opposed to tumor testing, which is genomic testing, which is looking at the mutations that may be present in that tumor that can hopefully guide our treatment. Now, the bulk of that is really done in the metastatic setting. So we have, for example, tests that we do on the tumor, such as looking for a mutation called PIK3CA, which can occur in about 40% of women with ER-positive tumors. And in the stage 4 metastatic patients, it means that we're able to target that mutation very effectively with a drug called alpelisib. But in the early stage setting, other than ER, PR, and HER2, in terms of the information on the tumor itself, we're giving anti-estrogen therapy, we're giving chemotherapy when the risk is sufficiently high, we're giving anti-HER2 therapy, but we're not looking currently at gene mutations in the tumor in the early stage setting. Certainly in the context of research studies, those evaluations are definitely going on. In triple negative tumors, we're looking at adding therapies like immunotherapy, which is now also approved in the early stage setting for preoperative treatment in triple negative tumors as well.
Thanks for addressing that and explaining that. Mm-hmm. One of our attendees had actually asked about the use of CDK inhibitors in early stage breast cancer. We know they're not approved right now in early stage breast cancer, but what's the research showing, and what do you think the future looks like?
Yeah, so we are very excited that we are moving some of our treatments that we're using in the metastatic setting when they're really effective. The thought is, well, why are we waiting until patients develop metastatic disease? If these drugs are really effective, what about giving them to a particularly high-risk patient population in the early stage setting? So there are 3 CDK4/6 inhibitors. There's palbociclib, ribociclib, and abemaciclib, and all 3 of these have been evaluated in the early stage setting. Palbociclib was looked at in a trial that looked at patients that received it after receiving standard upfront treatment with the intention of looking to see if there was a lower risk of recurrence. The trial was called the PALACE trial, and unfortunately there was no benefit noted with taking palbociclib. The ribociclib trial is an ongoing study. It's called the NATALY trial, and the abemaciclib study has been reported out at somewhat early time point, but we were really happy to see this decreased risk of recurrence by taking abemaciclib in the early stage setting for high-risk patients. Now, the question will come up with longer follow-up. Are we really curing these patients? Are we delaying recurrences? We're still following these patients, but it's not currently approved in that setting. But in a high-risk patient, for example, someone who has multiple positive lymph nodes, a very large tumor that's ER positive, HER2 negative, I have been considering the use of what we call adjuvant abemaciclib in the early stage setting based on this trial that was reported and showed a benefit.
Thanks for sharing that. And another person was asking in general about other research in early stage breast cancer that people might be able to get involved with when they're done with their hormonal therapy or with their ongoing targeted therapy.
Yeah, I think there are a lot of studies that we're looking at in the early stage setting that may help inform what we do in the future. The first thing that I would say that I'm really excited about is we talked tonight about tolerance issues to aromatase inhibitors and tamoxifen. There is a new class of therapy called SERDs, oral SERDs, serum estrogen receptor downregulators. They're currently being evaluated in the metastatic setting and now also in the early stage setting with the hope that they will be better tolerated than some of the drugs that I think many women struggle with, as we've discussed this evening. There are other ongoing studies in the early stage setting. We talked about CDK4/6 inhibitors. There are vaccine trials for early stage breast cancer that are ongoing. For HER2-positive disease, we have current studies that are looking at a really high or a really I would say important area that is an unmet need, which is reducing the risk of brain recurrence or CNS recurrences in HER2-positive disease. We're looking at strategies of adding additional treatments to our standard drug TDM1 in really high-risk patients to see if there's a decreased risk of recurrence, or especially with regards to CNS metastases. So definitely a lot of work going on in the early stage setting.
Great, thank you for sharing that. And certainly we talk all the time about encouraging our community to get involved in clinical trials, even when you're done with treatment. If there's a way that you can contribute, it's a great way to feel like you're doing something and also contributing to the future.
Janine, I'll just add in terms of another treatment that I think we should really highlight, because this was another area that we were excited to make progress. And this is for the patients that do have a germline mutation in a gene called BRCA, which accounts for actually a minority of all the cases that are diagnosed. A lot of women tend to think of breast cancer as a hereditary syndrome, but the minority of women that are diagnosed with breast cancer actually harbor a BRCA mutation. But for the women that do, there's a very important new treatment. It's an oral therapy called a PARP inhibitor. And it is a drug that has been shown now for women that are high risk early stage breast cancer with a germline BRCA mutation to be given in the early stage setting for a year. So this was a very important study that was presented at a major meeting, our major oncology meeting, and I think is worthwhile highlighting.
Absolutely. And you can learn more about that study at lbbc.org. I think it was fairly recently reported. So it's exciting. It's an exciting development in the early stage breast cancer space. I have a couple of, I'm going to circle back to HER2-positive disease with a couple of questions. One of our attendees is asking, in what situations would you recommend using Herceptin or a Herceptin biosimilar alone versus using it with Perjeta?
In the early stage setting.
Early stage setting.
So first off, we'll just pause to just comment on what a biosimilar is, right? So many people think that a biosimilar is like a generic, but it's impossible to make an identical copy of a biologic agent. So these drugs are made through cell lines, they're living cell lines, and you can't directly carbon copy the drug to make it a generic. But a biosimilar is a treatment that is approved by the FDA and has shown very good similarity to what we call the reference product. So for example, Trastuzumab or Herceptin is the brand name of this drug, and there are several now biosimilars. And the important thing to realize is that these drugs have been studied very carefully and have been shown to be extremely similar to the reference product, in this case trastuzumab, and effectiveness has also been looked at as well. So a patient shouldn't feel in any way that they're getting an inferior drug of any sort when they receive a biosimilar. So I'll take the question and just change it a bit and say, when would I give Herceptin / or a biosimilar versus Herceptin in combination with Perjeta or Pertuzumab? In the early stage setting, we often give both drugs in combination with chemotherapy when we're giving it as neoadjuvant or prior to surgery. In the adjuvant setting, if you had surgery up front, we know women that had lymph node positive disease really benefit from taking both Herceptin and Perjeta together, but it depends on, again, the stage of your disease, whether you required neoadjuvant or you just had adjuvant therapy. We're often referring patients early on for consideration of neoadjuvant therapy. So less patients with multiple positive nodes or bigger tumors are ending up in the OR. That's something that I think we've made progress on. A lot of our surgeons are sending those patients to us up front, and many of them are getting dual antibody therapy in combination with chemo as neoadjuvant treatment.
Thank you. And when someone is getting multiple HER2 targeting drugs, are there any particular side effect risks that they should be thinking about that might be different if they were just on trastuzumab alone or a biosimilar alone?
So the good news is Pertuzumab hasn't been shown to have any additive cardiac toxicity. So if your physician indicates that you need both of those antibody treatments, there's no additive risk in terms of the cardiac toxicity. Pertuzumab can cause some issues with rash and diarrhea, which can be a little bit problematic for some patients, but I find that most people are able to get through it okay. In terms of the other therapies that we give that are HER2 targeted in the early stage setting, we touched on Neratinib a while ago. That treatment is particularly tough in that it has a very high chance of causing diarrhea. But what we have done is really make a lot of progress in doing what we call a dose escalation strategy, where we don't start with the full dose. We go slow over the period of about 3 to 4 weeks and get someone up to the full dose, and also use anti-diarrheal medication preventatively. And that's been shown to be really helpful in reducing that risk of diarrhea.
Thanks for answering that. So we only have time for a couple more questions. I have one question about whether there are clinical trials in the early stage setting looking at immunotherapy in these subtypes of breast cancer.
Yeah, absolutely. So we just had an approval based on a trial looking at triple negative patients with the addition of immunotherapy to chemotherapy in the preoperative setting, and that has led to an approval. We also have ongoing studies of looking at immunotherapy as what we call adjuvant treatment alone. So for example, patients who go for surgery up front and whether or not they need immunotherapy in addition to chemotherapy. I think a lot of our progress in breast cancer has been at looking at immunotherapy in triple negative disease, but for HER2 positive disease, there are also studies that are looking at immunotherapy. Right now, we have a protocol that's open at my institution. It's a national study looking at our standard backbone of taxane chemotherapy, Herceptin and Perjeta in the metastatic setting, and looking at adding immunotherapy to that again in the metastatic setting, but with the hope that, you know, in the early stage setting, we may also see a benefit in HER2 positive disease, which will remain to be seen.
Great. Thank you so much, Dr. Mahtani. And thank you so much for all of your amazing questions. I apologize that we weren't able to get to all of your questions, but there were so many and they were all really excellent questions. But before we wrap up, Dr. Mahtani, Are there any closing thoughts that you would like to share with our attendees today about what you're seeing?
Well, the first thing that I would just emphasize is that, you know, we've all been through this pandemic, and it's been challenging for all of us personally, work-wise, balancing our childcare responsibilities and work and home. And I just want to remind everyone about the importance of screening mammography, right? A lot of us have put off screening mammograms, and I'll tell you that in my practice, I've seen an increase in the number of patients that have come to me with later advanced stage disease or even locally advanced disease. And we know in breast cancer that diagnosing cancer earlier is completely linked to better outcomes. So, you know, we're making progress in getting the word out about the importance of screening mammography. We've made an amazing amount of progress, but with the pandemic, I know that up to 1 in 3 women have put off screening mammography, and I would encourage you all to go back and get your mammograms done. We've put in place safety measures in the office. It's safe to come in, and don't delay it, especially if you feel something.
Thank you so much, Dr. Mahtani, and thank you so much for sharing your expertise this evening with our community.
My pleasure. Thank you for having me.
So as we're wrapping up, I just want to quickly again thank our sponsors for this program, AstraZeneca, Genentech, and Lilly Oncology. And I really want to thank all of you for spending this time with us, for your excellent questions. I hope we were able to address some of your concerns. We will post a video of this program on lbbc.org as soon as possible. And you should be receiving an email from us with a link to an evaluation. We really want to know what you thought of the program and what we can do better. So please take a moment to fill that out. LBBC is here to help you cope with the medical, emotional, and practical challenges of living with breast cancer. You can do that by contacting us at our helpline or by joining one of our closed Facebook groups, such as breast cancer support for all ages and all stages. And it's a great place really to connect with other people about their experiences and get tips around some of the questions that you had today, particularly around side effects. It helps a lot to hear from someone who's been through it. So again, I want to thank Dr. Mahtani, and I want to thank all of you. And I hope that you have a wonderful evening, and we'll see you again soon.